patient. If the patient anticipates what the doctor's doing or hints to the doctor anything, the patient's the one that's going to lose credit on their exam. Okay, so you don't want to do it. Okay, so I'm going to have him have a seat right here at the end of the bench, right here, facing that way. Okay, and I'm just going to start at the top and work my way down. So keeping in mind, I'm going to have him remove his chain there. Learn not to say necklace or chain.
I like your chain.
And doesn't it make sense to have him go ahead and remove his shirt, right? Because there's only going to be cervical stuff, and then when I get down to the first rib and everything else, the shirt needs to go. So instead of taking the chance on making a mistake and leaving the shirt on, I will not remove it.
You said the patient can't do anything.
Well, you can do that under my direction.
That was great.
I can see that one spread. You should stop that. Take your shirt off. Okay, so my first thing I'm going to do is ask him if I can palpate him for the duration of the exam.
Yes, ma'am.
Thank you. Okay, so the first thing that I'm going to locate are the transverse processes of C1. And this is a bilateral palpation, so patient is seated, facing away, palms up. Doctor stands in this situation and 2 other times is directly behind the patient. So I'm going to find the landmark of the mastoid process. I'm going to slide slightly inferior, just a roll down, slightly anterior, and then I'm going to turn my fingers and push from a lateral to medial direction, feeling for bony resistance, and I've located the atlas transverse processes. I'm being careful not to go too far anterior and avoiding the styloid process. That would be 100% right there. Next, I'm going to find the temporal mandibular. Yes, ma'am.
Would y'all call out if you want the left side or the right side first?
With atlas, it's bilateral.
Okay, cool. Just make sure.
So I'm doing the bilateral stuff first.
We have to verbalize all of this, correct?
Yes.
Well, and
Exactly like
you
you
want
said.
them like you're verbalizing, not the step by step.
Just what I just did.
Okay.
Right?
Okay.
We have a landmark, which is a starting point, and then we have a roadmap to get to where we need to go.
Okay.
A lot of people will palpate the atlas, but they'll use the flat part of their fingers. You can't feel the atlas when you do that. You feel just soft tissue. I've got to turn lateral to medial and really accentuate this, y'all. Pushing lateral to medial, feeling for bony resistance, and I have now found the transverse process of the atlas. Making sure to avoid the styloid process, you must say that. Okay? We can see if you're on the styloid process because what do you think your patient's going to do?
Yeah,
He's
correct.
going to flinch, right? So if we see that, we're probably going to come and verify what you were touching. So do this exactly like this and stay here until we give you something else to do. Okay. Next, what we're going to find are the temporal mandibular joints. So I'm going to, starting point is going to be the tragus of the ear. I'm going to go slightly anterior to that. There's a little vertical gap. I'm going to ask the patient to open and close his mouth. And what I'm feeling for is symmetry, listening, feeling for popping and clicking, and asking the patient if he feels pain.
No.
Okay? Temporal mandibular joint. Next are the first ribs. And so with the first rib, we'll ask you to find one on the right or one on the left, right? So what you're going to do, it's still going to be bilateral. You're going to take your stiff-finger hip, you're going to slide down the lateral margins of the neck. You're going to be posterior to the clavicle, and you're going to wrap the trap to pull it out of the way, right? So you're going to be anterior to the trap, posterior to the clavicle. And now I'm going to palpate from a superior to inferior and lateral to medial direction, feeling for bony resistance, and I've now found the right first rib. What people do, which is incorrect, is people want to go sliding along the upper trap. The minute you do that, you're on rib 2. I can guarantee it. Right there, the first rib is underneath your sip. You've got to stay posterior to the clavicle, anterior to the trap. We call that wrapping the trap. Palpating superior to inferior, lateral to medial, feeling for bony resistance. You must tell us, because a rib should feel bony, right? Maybe you take one or two hands away.
We should say that on every test except for the lumbosacral junction, right? Feeling for bony resistance. I mean, that's basically
Right.
Right.
Uh-huh.
That's a cue. We should know.
That's where we're living. We're finding the bony.
That's right.
Okay. Next, we're going to move on to the cervical articular processes. So when we're going to give you a right or a left, If he's in this position, can I get on the right or left side of him?
No.
No. So this happens all the time in practicals. People get over here and they're on the left side, but they're not on the left side. So in order to have him positioned properly, I'm going to ask Greg to come to the end of the table and face the wall. And then now I have easy access to the right or to the left. Okay? I'm going to find a structure on the left so that you all can see it. So somebody give me a level. C4, left articular process.
Yes, ma'am.
If I'm finding the C4 articular process, the closest landmark to C4 is C2, so that's where I will start. I'm going to support the patient's head and neck. I'm going to get him relaxed. I'm going to look for and palpate for bony resistance here, and that's the C2 spinous process. I'm going to count down to C3, C4, and I've now located the C4 spinous process. I'm going to take my SIF and IF, and I'm going to pull the soft tissue back out of the way. And now I'm going to push forward from a P to A direction, feeling for bony resistance, and my thumb is on the left articular process of C4.
Are you supposed to say like how far out you're supposed to go?
3/4 of an inch to an inch. Yes, you must give us those measurements. That's part of the verbalization. Did I not say
No.
that?
No, not 100%.
I'm so sorry.
And is your thumb, and you say my thumb found the?
The left C4 articular process is under my thumb.
So 3/4.
Yes, those measurements are extremely important, okay? If you give us one and don't give us the other, you miss that point altogether. And it's significant, it's 4 points, so we don't want to do that. Okay, somebody give me a lower cervical articular process to find. C6, left articular process. So to find the C6 left articular process, I'm going to start at the closest landmark, which is going to be C7. And so I have to locate C7. And in order to do so, I have to find the vertebral prominence. Now, in this scenario, I am finding C7 to go to C6. That's going to be a different verbalization, same process, different verbalization than if I was asked to find the vertebral prominence. And I'll show you the difference in just a second. Okay, so go ahead and have the patient bend his head forward as far as you can. Wow, there we go. Hello. Gonna get him completely relaxed because I need to feel passive range of motion. So my SIF and IF are on the two most prominent. I'm gonna bring the patient back into an extension range of motion, feeling what the spinous processes do. And the spinous process that's underneath my IF is translating or retracting away from my finger, so therefore that, since C6 is the last freely movable, that makes that C6, and so that's the vertebrae that I'm going to locate. So here you can see there's really not tissue, right? It's different down here lower. So you don't have to go out, you still have to go out 3/4 of an inch to an inch. Just slightly pull it back, and when you do, this finger comes off of there, right? This is just to get you level with the segment, because a lot of students will be here, and then they'll go up high or go lower. That's to line you up, kind of like you do with the, in the pelvis, how you do with the inferior notch in S2. You're at that level, so you're just going to come straight out, right? Please don't cross your legs. That tenses his muscles when he does it. So now I'm going to push from a P to A direction, and the left articular process of C6 is under my thumb. Okay. So I talked kind of through the VP, but let's say we're supposed to find the VP. The vertebral prominence is the best position to find it is in the seated position. So if we ask you to find the vertebral prominence, that's your topic that you're supposed to pursue. Here's how that would look. Okay, patient's head all the way down. I'm going to put my SIF and IF on the two most prominent vertebrae. I'm going to get the patient passively relaxed. I'm going to bring his head back into full extension, feeling the spinous processes. And what I find on this particular patient is that the vertebrae underneath my index finger does retract away, so therefore that makes this vertebrae under my index finger C6, and that would make, in this situation, his vertebral prominence C7. However, if that one did not retract, that would mean that my index finger is on C7, and that his VP in this situation would be T1. You must tell us all of that, not only what is happening, but what if. Okay, so I call that ownership. You have to have ownership of the VP, and if we're ask you to find the lumbosacral junction, you must have ownership of the lumbosacral junction. So there's a difference in using it as a landmark to go somewhere else or ownership of those two things. Okay, Next, we're gonna move on down to the thoracic, so let's have our patient lie face down and make sure that we give him ample room to breathe. He's in a relaxed position, the arms at the side. Doctor's stance is going to be scissor stance, standing right next to him. It's good I wore my scarf so y'all can see the epidermal notch. Did it on purpose.
Women aren't allowed to wear jewelry, right?
Women or men. We don't want jewelry. The best thing is for women to have your hair up so that it's not in the way, because otherwise several practicals I've been holding the hair up on somebody, and it's just go ahead and get it up out of the way.
And
Okay?
no rings or earrings.
Rings are okay, but you're going to get, like if you see in practice, I don't wear bracelets, rings, watches. I just don't want, the possible chance of scratching somebody. So it's just best on both that you don't have anything on. Okay, so I've just identified the vertebral prominence on him, but I need to go ahead and verify, right? So I'm going to have him come up on his elbows, drop his head forward, two most prominent. I'm going to very quickly, okay, that one retracts, so his VP is C7, so go ahead and relax down. Okay, so there's C7, okay? Somebody give me a thoracic transverse process to find on the right side.
T4.
T4, I'm starting at T1, I'm going to use a finger slide technique, T2, T3, T4, I've located spinous process of T4. I don't want to lose it, I've worked really hard for that, right? So maintain your point with your inferior contact. Don't get too many fingers going in here because it makes it really hard for us to tell what you're doing. We see a lot of this and I'm just like, what is going on? So maintain your spinous process, right? Now, to find T4, how far up do I need to go?
One spinous process.
One spinous process, out lateral, a full inch. That's way out here, y'all, okay? From there, I'm going to back up my thumb with my other fingers. I'm going to lean with my epidermal notch over the center of the spine. This is not the center of the spine. This is the center of the spine. And then I'm going to lean in with my body weight. And I'm going to wag the spinous process of T4, therefore verifying that I'm on the correct transverse process.
Do we need to verbalize that we're taking the slack out of the
Yes,
skin?
that's the next thing I was going to say. So if you don't take slack out, that's what that looks like, and it's a lot of skin movement. When you do take the tissue slack out, it's a downward pressure, and the skin is not moving. Okay, that's what we mean by taking the tissue slack out. You must state that. Okay, so that's the verification. So we'll ask you to find T4, right transverse process, and verify it. And you verify it by doing the WAG. Huh?
T8.
T8. Okay, I've already identified his VP, so I'm going to count down. T1, T2, T3, T4, T5, T6, T7, T8. And y'all, we can tell, based on shortcuts, we can tell whether you're at the appropriate level or not. So if you be very exact, okay? So I'm now at the spinous process of T8. I'm going to come up how many?
2 interspinous.
Two interspinous spaces, right? 1, 2. Out lateral how far? I'm going to back up my thumb. I'm going to get my epidermal notch over the center of this patient, and I'm going to take the tissue slack out downward and pushing, wagging the spinous process. If you do not feel it wag, roll your thumb down just a little bit, and that's exactly what I had to do with this, is just roll it down a little bit, therefore verifying that I'm on the correct transverse process. So know your spinous spaces, know your interspinous spaces, and know those lateral measurements, okay? So if you kind of just look at the anatomy of the body, here's where these transverse processes are, okay? Mammillary processes are real close to the spine. Articular processes are in line with where the hair growth is, right? So these are the furthest apart, 1 inch. These are 3/4 of an inch to an inch, and these are 1/2 to 3/4 of an inch. Okay, so somebody give me a lumbar. Who? L3 mammillary process on the right. I'll be happy to find that for you. So I'm going to tuck this patient's breeches, right? So we're
With
just
his
going to,
permission, right?
huh?
With his permission first.
Yeah, well, he's given me permission for the
Okay.
entire lab, so, if this were a female, what would I have to do? Drape her, right? Okay, and I would be inside of the drape, right? Okay, everything is skin on skin until we get down yonder, right? Okay, so Dr. Stents, side of the patient, scissor stents. I'm gonna find the inferior angle of the ribs. When I do, I'm gonna knife edge in to the soft tissue, drop down to the iliac crest. My thumbs are going to pivot in a windshield wiper down fashion. I've now located the inferior notches of the PSIS. Is that ticklish?
A little bit, yeah.
Okay. Inferior notches of...
Ooh, now we know his sweet spot.
Okay.
Just kidding, right?
Now, people mess this one up all the time, but just look at it, right? Does this, which looks more natural? This or this? This? It's like an eye doctor. This one or that one? I don't know, they look the same. No. That or that? If you do this, you're messed up because you're gonna start counting with your superior hand, and that's a no-no, okay? So we're gonna pivot medially and bisect, not dissect, bisect the point between our thumbs, right? To the S2 tubercle. I'm not gonna take my finger off of the S2 tubercle. Y'all don't take your finger off the S2 tubercle. This is too much going on down here. You'll lose it. So slide cephalad off of the sacrum, and right there is a soft tissue space. That's the lumbosacral junction. However, I can verify it with this hand over here. So now the inferior hand is gonna come off of the inferior notch onto the sacrum itself, okay? Don't come over to S2 because then you're in the way. Just come off of the inferior notch onto the sacrum, feeling bony resistance, soft tissue. So what I've done is just verified that I have now verified that I was on the lumbosacral junction. A lot of work went into that, right? I do not want to lift this finger yet. So superior hand stays right there, inferior hand now takes over and finds the L5 spinous process, and this hand can now come away. I'm on L5, and where do you want me to go, Alicia? L5, L4, L3, spinous process. From the spinous process to locate the mammillary process, I know it's superior, right? So it is how far up?
One inner spinous
Upper spinous space. Out lateral how far?
Half inch to 3/4.
Half an inch to 3/4, and I should be over the right mammillary process of L3. Do I wag?
No.
No. Okay. So just know that your thumb is over it. Just like here, our thumb winds up over it, our thumb winds up over the articular process.
So, question, it was up 1 into spinal space?
One interspinous space, out lateral, 1/2 to 3/4 of an inch. Okay. Now, I used the lumbosacral junction to get me there. I didn't have to verbalize all of that. I could have started right at the lumbosacral junction. Right? I could have started, okay, I found the lumbosacral junction. I'm going to count up from L5. If you are given, your quest is to find the lumbosacral junction, you must do exactly what I did. Very exact. So let's say I'm just using the lumbosacral junction to find L5. That's what this would look like. I'm sorry, I couldn't Dr. Baggett's taking the shirt off his students. She's tickling her.
Hey, get this on video. Let's get it out.
Okay, inferior angle of the ribs. I'm about to palpate you. Okay, here's how that would look. Located lumbosacral junction. I'm going to count up from there to L5. So I didn't have to talk through any of that.
As long as you're
If-
using it as a landmark and you're not living in it.
Yeah. If I'm supposed to
Owning
find the
it.
lumbosacral
Okay.
junction, I gotta own it, right? Okay, so I owned it a minute ago. Do y'all wanna see it again?
Yes.
Okay, do this exactly like this. I'm about to palpate you. Inferior angle of the ribs, knife edge in to the soft tissue, drop down to the top of the iliac crest. My thumbs now do a pivot in a windshield wiper down fashion until I've located the inferior notches of the PSIS. My superior finger rotates medially, superior hand, index finger. From S2 tubercle, I'm going to slide cephalad off of the sacrum until I find a soft tissue space. My other hand, inferior hand, now leaves the inferior notch onto the sacrum, feeling bony resistance, soft tissue. So I've just verified that I have located the lumbosacral junction. That's ownership. Yes?
Do you have to state that on the iliac crest is higher than
Nope, just make sure you find it. Yeah, that's why we knife edge in, because it's real easy, if you don't knife edge in, it's real easy to wind up down here when the iliac crest is really right here. Right? It would be real easy to wind up here, and then everything's thrown off from that point. Okay, so from here, sacral hiatus, okay? I've gone through that whole procedure. I found S2 tubercle, right? Now what I'm going to do is turn cephalad. I'm going to slide off of the S2 tubercle, go over a hump until I find a flat spot, and I've now located the sacral hiatus. The rest of what I'm going to find is not going to be skin on skin, okay? So, ischial tuberosity. Which hand do I use for that? Right? Okay. So I'm going to look at the inferior fold of the glute. I'm going to look at the mid thigh, and that's my crosshair, right? So I visualized it. I'm going to let the patient know I'm going to be finding his ischial tuberosity. And so with my superior hand, with my sights there, I'm going to go superior, anterior, medial, SAM to the ischial tuberosity. If you follow that, you'll be right on it every time. Okay. Next, we have the
Sam.
greater trochanter.
SAM.
I can tell y'all, I'm not going to test you on the greater trochanter. We will, second part, because I'm changing things up a little bit. Pardon?
Extremities.
Yeah, we're going to cover extremities, so we're going to get that greater trochanter. So something that you don't have to worry about for this test.
You're so sweet. Thanks.
Well, it's just something, why have you study it when I know it's not going to be asked? You know what I mean? So, but it is important. And I'll just, what's that?
I said logic.
I wish it really was like that.
Well, just bring your arms back by your side. I'm going to just do it real quick so you'll see. So, mid-axillary plane, iliac crest, fingers drop down to the greater trochanter. I'm going to bring the leg up into flexion and medial and laterally rotate and fill in for the greater trochanter to move on between my fingers. Okay? Next is palpation on the anterior pelvis. These are not skin on skin, so I'm going to have my patient turn supine. Okay, the first thing we have to find is the anterior superior iliac spine. So what we're going to do is find the top of the iliac crest, travel down until we get to the notches on the front, which are the ASIS. Okay. Next, what we're going to find is a pubic tubercle. So, with our patient, if you do not have them move their male anatomy in the practical, it's going to be an uncomfortable situation for them and for you. So if you have a male patient, please do this, okay? So it's going to be one side or the other. It's going to be the right or the left. I'm on the left side, so where do I want him to go? Right side, okay? Make sure you turn around in the practical situation, okay? So what I'm going to tell my patient is that I'm going to have you move your male anatomy to the left side, right side. I'm on the left side. It gets confusing. I'm on the left side. We're all going to turn around while he does that, and he's going to tell us when we're ready. So turn around.
All right.
Okay. Now from here, what I'm going to have him do is place the heel of his hand on his umbilicus, drop the fingers down, feeling for a bony prominence. Okay. You have to tell him what they're feeling for. Okay. Once he's found it, have you located that? Stay there. I'm going to replace your fingers with mine, okay? And you can take them away. I'm going to come towards me, never across, towards me, 1/2 inch to 3/4 of an inch, and right there is a pubic tubercle. I've located it. I'm going to take my hand away. I would verify that, doctor, by tracing the inguinal ligament from the ASIS to the pubic tubercle. Okay, so you must tell us how you would verify it. You don't have to show that you would verify it. Okay? That's all, folks.